Hi everyone, this is Tim, your Block 3 lecture instructor, and this PowerPoint voiceover is going to be on kidney disorders. Primarily it's going to be on pyelonephritis, glomerulonephritis, chronic renal insufficiency, acute kidney injury, and urosepsis. It's kind of lengthy, but it's pretty informative. I try to keep things as basic as possible. If you have any questions, let me know. The first couple slides are actually pictures of the kidneys and the in the anatomy of inside the kidney. Just familiar yourself as far as what the kidney does, what is actually purpose of the entire organ for the body as far as the flushing of fluids and the excreting of waste. So again, just familiarize yourself, because once you understand all of that, everything else seems to kind of fall in line and is pretty basic. So here's your first picture, which is the kidneys, ureters, and the bladder. Here is your nephrons. This is actually inside the kidney. The big important parts of this are going to be the glomerulus, the Bowman's capsule, and the tubules. Those are probably the most important, because those are actually what pulls back in the electrolytes and excretes electrolytes based on trying to maintain homeostasis. So remember, the kidneys are constantly trying to balance things out within the circulatory system. Here's the formation of urine. So the afferent arteriole is what actually causes the circulation to go through the glomerulus, and then it's the actual Bowman's capsule that is going to pull in what it needs, and then if it does need it, it actually pushes it back through the circulatory system, and if it doesn't, it actually produces urine and will excrete it out of the kidney. For number one is the filtration of the glomerulus. I'm not really expecting you to know all these numbers. I just want you to understand that these are probably the most important electrolytes and byproducts of the circulatory system, and what the kidney does to help pull in and push stuff out. Again, you're wanting to know this just because of the fact that it's all about the balance. We can start off with water. If you're dehydrated, obviously your kidneys are going to try to pull in as much as it possibly can to keep you as hydrated, and water follows salt and vice versa. So if you need more of it, then it's going to maintain it, and if it doesn't, it's going to excrete it. The chloride, bicarb, and potassium work the exact same way. What I want you to know as far as the potassium is that you have to remember, if there is something wrong with the kidney and it's not able to function the way it's supposed to, a lot of these electrolytes are being held and not being able to be excreted, and potassium actually affects every muscle in the body, including the heart. So keep that in mind when you start to look at these electrolytes and go, this has been kept and it's getting on the high side. What else is it really affecting? We've got the glucose, the urea, binding creatinine. I mean, those are indications of whether or not your kidneys are actually functioning properly. So like I said, just kind of keep these all in mind and kind of figure out, well, if it's too high, what else is it affecting? If it's too low, is it actually affecting something else? So all right, so we've got the kidney, the glomerulus. Each nephron contains tufts of capillaries that filter large plasma proteins and blood cells. The tubules, they receive filtrate from the glomerular capsule and reabsorbs water and electrolytes through active transport. And the loop of Henle is passively reabsorbing sodium and chloride for osmolality, and then they actually also passively and actively remove sodium and water. So again, this is pretty much the kidney in a nutshell and what it really does, and it is basic, but I think if you get too in depth with what each individual part of the kidney does, it starts to get too complicated, in a sense that, again, as a bedside nurse, you're really looking at what does the kidney do. You're looking at labs to be able to prove whether or not it's functioning correctly, and you're trying to make sure that whatever is happening with your patients, you're actually correcting. So so keep it pretty basic, and I think you'll do well. All right, so for the first disease process, this is pyelonephritis. It's the inflammation of the renal pelvis, commonly caused by bacterial infection, urinary flow obstruction, or reflux. So if you've listened to the other PowerPoint, which was on the urinary disorders, basically the way I think about it is, a patient gets a UTI and they're not doing anything to really take care of it, whether it be not being compliant or just not knowing that they actually have the UTI. As it gets worse, it travels higher up through the urethra to the bladder, from the bladder to the kidneys, and that's where this comes in. So for the most part, your patient has probably had some sort of urinary tract infection that has actually traveled up to the renal pelvis. Again, it's caused by bacterial infection. Most commonly, it's actually from E. coli, and I'm not trying to sound crude, but it's really more of hygiene and not carefully maintaining the peri area, and then that's usually how that kind of gets there. Pyelonephritis can be acute. It can progress to bacteremia, which is obviously a blood infection with bacteria, or it can eventually cause chronic pyelonephritis. Chronic pyelonephritis is recurrent attacks of the pyelonephritis. It's dysfunction of the nephrons and causes scar tissue. So if your patient, gets pyelonephritis over and over and over and over again, it actually will start to shut down the kidney because it's starting to affect the interior and causing scar tissue. The ureters become fibrotic and become narrowed, which is not very good because if you have listened to the other PowerPoint, we talked about the kidney stones, you want things to be as dilated as possible. So, and being narrowed is not allowing urine to flow as freely as it should. And again, this chronic pyelonephritis can actually lead to renal failure. So, symptoms of pyelonephritis, we've got fever and chills because that's a sign of infection. We've got nausea. You've got definitely flank pain on the affected side. You'll have a headache, dysuria, frequency and urgency, cloudy, bloody, foul-smelling urine, and increased white blood cells. So for the symptoms, it seems to be pretty easy in the sense that, again, the fever and chills is from the infection. Increased white blood cells is because of infection. The frequency and urgency is because your kidneys are trying to care for itself and try to get rid of the infection by flushing it out. So the more you drink, the more you pee, and you want to stay as hydrated as possible because even if you aren't drinking enough, your body will still flush itself out, trying to get rid of the bacterial infection. The flank pain on the affected side is because of the fact that the infection is in your kidneys. I mentioned before I took care of a patient this last weekend who did have pyelonephritis, and I believe it was on her right side. The physician actually assessed that area and was doing some auscultating and some, assessment of that area, and it really, really hurt. I mean, she practically jumped off the bed. So it's definitely painful. Diagnostics, you're going to do a urine dipstick testing. They're going to do a microscopic analysis or a UA. It's going to be marked with polyuria or a positive leukocyte esterase test, microscopic hematuria, or a positive heme dipstick. So essentially, this is an amped up version of urinary analysis. You're going to pee in a cup, they're going to send it to the lab, they're going to test it, they're going to find out exactly what the cause is, and then they're going to prescribe an antibiotic that's susceptible to that bacteria. Interventions, you're going to monitor for vital signs, especially temp. You're going to encourage fluid intake up to 3,000 milliliters per day. It seems like a lot, but two things. One, the more you drink, the more you pee, and the more you drink, the more you're actually going to dilute and try to help your body flush out the bacteria itself. It's also going to reduce the fever. So you're going to monitor eyes and nose, so you want to be able to be very strict about it. Output is at least 15 mLs per 24-hour period, which doesn't seem a lot in the sense that you are drinking 3,000 cc's a day. But in the same sense, too, you are really trying to hydrate yourself and in trying to be on the positive as opposed to in the negative of your ins and outs. You're going to do daily weights. Daily weights are always a good idea, especially if you're drinking 3,000 cc's a day. 3,000 cc's a day and retaining that much fluid, your weight obviously is going to go up. And just because you're taking care of a pyelonephritis does not mean that you're not taking care of someone who has pyelonephritis, but also has comorbidities like CHF and COPD. So you got to be able to balance out what they're able to consume, how do other organs function, and how is it going to affect them, and not putting them into more problems. You want to do adequate rest. A patient that had the pyelonephritis this last weekend, she literally slept all day long. She didn't feel good, but she really just slept a lot. You want to put them on a high-calorie, low-protein diet. The kidneys are what processes proteins. So if the kidney is already working hard to care for itself based on the bacteria infection, you don't need to add more proteins for it to work harder to try to break that stuff down. You want to do a warm compress or bath for flank pain. That actually helps a lot. One, it actually dilates things as much as possible, so things can be a little bit better, but it also, the warmth itself actually makes it feel better. You're going to prescribe analgesics, antipyretics, antibiotics, and antiemetics, and you're going to follow up with a UA after so long to make sure that what you are treating the pyelonephritis for, as far as the antibiotic, make sure that it truly is working. They will also probably end up doing a UA after antibiotics are done because they want to make sure that there's not still another problem or it doesn't turn into a chronic pyelonephritis. The next disease process is glomerulonephritis. It's a proliferative and inflammatory change within the glomerular structure. Essentially, it's destruction. It's inflammation and sclerosis of the glomeruli. And essentially, you will have loss of kidney function. The cause is immunological, or it can be also autoimmune. Most commonly, it's from a strep infection and the history of pharyngitis and tonsillitis, which seems interesting because people have had tonsillitis and had pharyngitis in the past. We also probably had immune systems that were able to care for the rest of our bodies while we had this, so it probably wasn't doing too much damage. But again, you're taking care of people who are sick or have other comorbidities. Adding something else like pharyngitis and tonsillitis, and CHF and COPD and all the other stuff, or even something as simple as diabetes, this definitely can actually affect the kidneys. Symptoms of glomerulonephritis is going to be gross hematuria. It's going to be dark, smoky, red-brown urine. It's going to have proteinuria that produces a foamy urine. I've actually seen this, which is very interesting. You have your patients, especially with guys, they stand to urinate and they go and it actually foams in the bowl. It's actually quite interesting. It's going to have a moderately high urine specific gravity. What I do need you to know or remember is that specific gravity is 1.010 to 1.025, which is a normal range. One thing that I've also wanted to mention too is that the lower the patient is hydrated, urine specific gravity actually increases, and with hydration, the more that you have them drink, the more hydrated they are, the lower the specific gravity actually gets. The reason why I bring this up is because with the kidneys, we talk so much about 3,000 cc's a day to flush out the kidneys, and making sure you're doing eyes and nose, and making sure you're doing these things, and making sure all the electrolytes that are being excreted aren't making your patient hypo, kalemic and natremic and all the other stuff. So just remember that we want them hydrated, but we also don't want to flush them to the point where we're flushing out electrolytes that they truly need. So let's see here. Also, for symptoms of glomerulonephritis is a low urinary output, a low urinary pH. The UA, the urinary analysis, will have large numbers of erythrocytes. Your patient will also have nausea and vomiting, abdominal and flank pain, which makes sense. They'll also have edema. What's happening is that the kidneys are not functioning correctly. You are actually retaining a lot of fluid. With that retention, you're going to get the edema in the third spacing. So you want to look at that, and The next symptom is shortness of breath. So with the shortness of breath, you're really looking at ascites and pleural effusion and CHF, because not only are they retaining the fluids because their kidneys are not functioning correctly to flush it out and actually excrete all the urine and all the fluids that they're consuming, but their heart's not pumping right, or their lungs aren't able to, you know, exchange that fluid. And the ascites, I mean, let's have, let's say here, 36-year-old female comes in with a UTI. It ended up turning into pyelonephritis, and this 36-year-old female is also an alcoholic, and she's been drinking for the last 20 years. With ascites and having fluid already built up, and then pyelonephritis on top of it, she's not able to actually pull out the fluid in any manner, so it just turns into a bigger mess. With the fluid overload, you're going to have hypertension, obviously, and then you're also going to have an increased bunning-creatinine because the glomulars are not actually filtering out the byproducts very well, so the bunning-creatinine actually goes up. So for diagnostics, you're going to do a UA. The UA will actually show red blood cells, white blood cells, which is an indication of inflammation and infection, and it will also actually show a high amount of protein in the urine because of the fact that the kidneys can't necessarily break it down and utilize it the way that it should. And because the kidneys aren't excreting the byproducts, the bunning-creatinine is going to actually increase. This is a picture of a normal kidney and the glomerulonephritis. I just thought it was pretty basic and simple that, like I said, it actually affects the glomulars, and, when they're not able to function correctly, then, again, you're going to start retaining fluids and retaining the byproducts. Interventions for glomerulonephritis is going to be monitor vital signs, especially blood pressure and temp, because of the fluid overload. You're going to do strict eyes and nose, and also inspect the urine as far as characteristics. You're definitely going to do daily weights because of the fluid overload, which is going to also be edema. The overload is going to be probably either contributory from ascites, congestive heart failure, or pulmonary edema. You're going to provide a high-calorie, low-protein, low-sodium, and low-potassium diet. If the kidneys are not functioning correctly and excreting what it doesn't need, it's going to hold on to that stuff. So you don't want to add any more sodium and any more potassium to their diet because it's already probably going to be elevated anyways, and there's no way of getting rid of it. And again, sodium and potassium actually affects a lot of things in the body, so we don't want to have to try to fix other problems too. You're going to administer hypertensives for the increased blood pressure. You're going to administer diuretics because of the fluid volume overload and the edema, and obviously they're going to do antibiotics. You're definitely going to do IV antibiotics for several days. Your patient will probably go home on orals, but IVs are going to be the best solution for the short term. The next disease process is urosepsis. So now we actually have gone from UTI to pyelonephritis to glomerulonephritis to now going into the bloodstream and causing urosepsis. It's gram-negative bacteremia. It's usually caused by E. coli. Common cause is from indwelling catheters. I mentioned in the other PowerPoint voiceover that the initiatives from the hospitals trying to lower their urinary tract infection rate because essentially every catheter we put in, as much as we try to make sure that it's sterile and that everything is as clean as possible, it doesn't always happen right. And when your patient actually gets a urinary tract infection by something that we have done, their admission and hospitalization become free, and that's money in your pocket. Major problem with urosepsis, the bacteria can develop resistant strains. So the E. coli actually gets into the bloodstream, and next thing you know, it's actually starting to become resistant to other antibiotics that we try to put them on. And this can lead to actual septic shock. Symptoms are going to be fever because it's a sign of infection. It's going to be another symptom is dysuria, frequency and urgency, urinating because you're trying to get rid of the infection. Your urine is going to be cloudy, bloody, and foul smelling. And I've seen this, smelled this before, and it's when they say foul, it could not be. It's probably the most worst thing I've ever smelled in my entire life. Other symptoms are going to be increased white blood cells because of the infection. Interventions, you're going to do a UA to determine what it's susceptible to as far as antibiotics. Once you found that out, you're going to put them on IV antibiotics for 3 to 5 days. And then after that, they'll be on oral antibiotics for another 3 to 5 days. And again, you want to make them as hydrated as possible. All right, so now we're on to acute kidney injury. So out of all those other disease processes, your kidneys are now getting to the point where they just can't do what they were supposed to before. They're tired. So acute kidney injury is a condition in which the kidney suddenly can't filter waste from the blood. So at this point, it's not doing anything. This is a picture of the kidneys themselves. Other reasons for acute kidney injury is going to be not enough blood supply to the kidney, kidney damage from other disease processes, or blockage of the urine, which based on the other PowerPoint voiceover, it could be kidney stones, it could be a blockage, it could be a million different things. But if urine's not passing and it's there, then it's going to get backed up and that's going to cause damage to the kidneys themselves. So what causes it? So here we talked about hypotension or shock. It could also be caused by blood or fluid loss, such as bleeding or severe diarrhea. It can be caused by a heart attack, heart failure, and other conditions leading to decreased heart function, or it could be also from heart failure, such as the heart, or organ failure, such as the heart and the liver. So the kidney damage is essentially that it's not getting enough blood supply, or it's not getting what it really needs to continuously work the way it was supposed to. Usually it's from circulation, and circulation is definitely related to the heart. So a lot of times if these patients have other issues, then it will actually cause damage to the kidneys. Symptoms are going to include decreased urinary output, swelling due to fluid retention. It's going to be other symptoms will be nausea, fatigue, and shortness of breath. And this actually makes sense. If the kidneys are not functioning at all, nothing is coming out, then everything that you eat and drink and break down and process has to go somewhere. So again, the symptoms of no urinary output are decreased. You're having the edema, generalized or third spacing, because of the fact that the fluid is not going anywhere. You're definitely probably going to have high blood pressure. The nausea is because of the fact that your body now is becoming toxic, and it's trying to take every orifice of your body and trying to expel whatever is in there out, so that way you can try to actually maintain homeostasis. And again, you're going to have shortness of breath because of the fact that fluid has to go somewhere, and the path of least resistance is always the lungs. Or you can have no symptoms, but experience whole body water electrolyte imbalance or fatigue, or you can also have insufficient urine production or urinary retention. I don't think this is something where you wake up and all of a sudden you just realize that you aren't peeing correctly. I think this is over a process of time. But in the same sense too, patients will start to realize, I'm not urinating as much as I used to before, or it hurts when I actually go, or I'm having some pain. I mean, these patients have other symptoms that usually brings them to a doctor and not feeling well, and then based on their symptoms is when they're diagnosed with actually having some sort of kidney issue. Let's see here. So diagnostics, they're going to measure urine output. They're going to do a urine analysis. They're going to do blood tests. They're going to do testing on blood and creatinine, phosphorus, and potassium, and they're also going to test it for proteins. They're also going to do what they call a GFR, which is a glomerular filtration rate, to find out if the kidneys are actually filtering something. They're also going to do some imaging testing, such as an ultrasound, to see if those are actually functioning correctly. And then this picture is a kidney biopsy. Patient lays flat on their stomach, and then they basically put a big old bored needle into their kidney and take a sample. It's very painful. Your patient will come back from this procedure. You're going to give them a lot of pain medication, and hopefully they. It lasts for at least a good 24 or 48 hours, but it's very painful. Interventions are going to be medications. You're going to do furosemide, and there was another medication that I actually pulled off, and the reason why is because it's something that I wasn't very aware of, and we don't use it very often in the hospital. So I thought, well, there's one less medication you need to worry about. But you're definitely going to give Lasix in order to help try to pull the fluid back into the circulatory system, and then whatever kidney function you do have, we'll be able to process it and get rid of it. Medical procedure is going to be dialysis, and I'll give you pictures of that later. They can also do stents if there is a problem with the kidney itself, as far as if there's something blocking it. They usually can go in and put a stent to allow circulation to continue and to become better. The stents can be placed in the bladder, the prostate, or the stents could be placed because of there's problems with the bladder, the prostate is enlarged, which is not allowing the urine to pass, or because of cervical cancer, it's also affecting the flow of urine itself. The stents can also be placed because of enlarged prostate, problems with nervous system that affect the bladder and urination. So if you have had patients who have had traumas, there's certain nerves that will be affected and it doesn't allow them to actually urinate. Kidney stones could be another reason why it's blocking something. So the patient's going through acute renal failure, and blood clots in the urinary tract. We talked but we will eventually talk about the TURP, which is the transurethral resection of the prostate. There's a lot of blood clots and stuff with that, and even though you took out one problem, which was constricting, not allowing urine to pass, but now all of a sudden you've got clots that are not allowing urine to pass. So anyway, stents are usually done for all these things in order for urine to pass better. And again, you're going to do fluid replacement because your body's trying to create homeostasis and will probably urinate as much as you possibly can. All right, so if that all else fails, you will have chronic renal insufficiency. And this is a gradual loss of the kidney function. Chronic kidney disease reaches an advanced stage when dangerous levels of fluid, electrolytes, and waste have accumulated in your body. So at this point, your potassium is like 6, and your sodium is 150, and your bile and creatinine are off the charts. And this is to a point where your body is literally becoming poisoned. Its treatment for chronic kidney disease focuses on slowing the progression of the kidney damage, usually by controlling the underlying cause. So, little quick story. I had a patient who was going through kidney failure, and the doctor who I've known for several years, this short, little, stocky guy from Argentina, has one of those cute little accents, and he was very nice and very sweet, and everybody just really seemed to like him, and even his patients really liked him. He had great bedside manner, and I had admitted the patient and called to consult. The doctor actually shows up, and he sat down on the bed and he talked to the guy for a little bit, and then he wasn't sobbing, but he actually started getting very teary-eyed, and he had told the patient, and the patient understood what he was talking about, but he had told the patient, we've done all we could for as long as we possibly could to keep you from getting this far, and here is the end, which was the fact that his kidneys weren't functioning anymore. So again, this is gradual and it's a slow progression, and there are things that you can do, whether it be medications or diet and odds ends of stuff, and they really for a year tried to do everything they possibly could, and it worked for a while, but again, it just eventually didn't. So the chronic renal insufficiency is, like I said, a progressive, slow problem. So causes could be type 1 or type 2 diabetes. It could be from high blood pressure, glomerulonephritis, or the inflammation of the kidneys filtering units like the glomeruli, interstitial nephritis, and inflammation of the kidneys, tubules, and surrounding structures. Other causes could be polycystic kidney disease, or prolonged obstruction of the urinary tract from conditions such as large prostate, kidney stones, or some cancers. And I want to bring up a good point too. What's really interesting is that as much as I was in the process of, or at least my train of thought was, we have the urinary tract infections, we've got the kidney stones, we've got the pyelonephritis and the glomerulonephritis, and those are things based on the fact that the kidneys aren't functioning correctly. But what's really interesting is that a lot of those diseases are, or at least with the prostate and the kidney stones and cancers, things like that and stuff, it's really more of your kidneys are functioning, but you just weren't getting it out in a flow that was normal. And because of that, it just caused so much stress in the kidneys that they just started to break down. So I just thought that was very interesting because, older gentlemen that are, 60, 70, 80, 90 years old will have prostate issues, and they'll learn to just live with the fact that they just don't urinate well, and eventually they'll empty their bladder, and then they just dribble, and they don't have a steady stream, or if there's hesitation and stuff, and that's just normal to them. But essentially, that puts a lot of wear and tear on the kidneys, and eventually it kind of breaks them down. So anyway, this thought was very interesting, especially with kidney stones, and that's not an uncommon disease process that, again, that can cause things to back up. So we also talked about vesicular reflux, a condition that causes urine to back up into your kidneys, and then recurrent kidney infections. So again, anything that causes either the kidneys not to perform the way they should, whether it be because of blockage or because of disease process, like bacteria, will cause your kidneys to fail. Symptoms. So these are pretty self-explanatory. Just because of the fact that, again, as I mentioned before, everything starts to back up. Your body's trying to get rid of the overwhelming high amounts of binding creatinine, things that are not actually coming out, the excretions and the poisons, I guess. So because of that, you're going to have a lot of issues. So obviously you're going to be nauseous. Your body's trying to get rid of it somehow, so you'll start to vomit. You'll have loss of appetite because obviously if you're nauseous and vomiting, you're not going to want to eat. The fatigue and weakness. You'll have sleeping problems. Changes in how much you urinate. You'll go from being able to not very much to not at all. You also have decreased mental sharpness, and I think that's mostly due to electrolytes starting to become higher on the trend. You'll have muscle twitches and cramps, probably more so based on chloride and potassium. You'll have swelling of the feet and ankles because things aren't actually being excreted. You'll have persistent itching. You'll have chest pain. If fluid builds up around the lining of the heart, there's another issue. So you also have shortness of breath because the lungs will actually start to fill with fluid, and the high blood pressure because the fluid has to go somewhere. Diagnostics are pretty simple as far as they're pretty much the same as what we've been talking about. So you're going to measure urine output, you're going to do your analysis, you'll do blood tests such as blood and creatinine, phosphorus and potassium. You'll also check for proteins. You're also going to check for the GFR, the glomerular filtration rate. You'll also do an ultrasound of the kidneys, and you'll do a kidney biopsy. So, interventions are going to be medications to treat. You're going to try to treat the blood pressure being high. You want to make sure that the cholesterol starts to become low. You're also going to become anemic because the kidneys function in the way that they're designed to help increase the production of red blood cells, and when they're affected in kidney failure, they're not doing that the way it's supposed to. You have the edema because of the fluid. You have low calcium and low vitamin D, and you also have high phosphate because it's actually being retained. So you want to make sure that they're on a low protein diet. All right, so here's, I think there's not many slides left, but this is all about hemodialysis. There's two different kinds. There's dialysis through a machine where they actually pull the blood out of your body, put it through a machine, and actually filters in, put it back in. Or you actually have what they call peritoneal dialysis, and I'll show you some pictures on that. So hemodialysis is used when the patient is acutely ill until the kidneys resume function, or for long-term replacement therapy in chronic kidney disease and end-stage kidney disease. The objective is to extract toxic nitrogenic substances from the blood and to remove excess fluid. This is through diffusion, osmosis, and ultrafiltration. They're going to have a vascular access. They're going to have a arterial venous fistula and or a arterial venous graft. Basically, what they do is they take a artery and a vein, and they basically sew them together, and they actually put them. Usually, it's in your arm, and they put them together because that way the artery can actually pull fluid off, go through the machine, and then the vein actually goes back and pushes it back through the body. So here's hemodialysis system. It's actually a pretty good picture. So again, they're pulling the arterial blood out. It's going through the actual filtration system, and the venous blood goes back in. I think for the sake of the picture, they use a wrist, but for the most part, it's usually forearm or bicep area. You probably could do it anywhere, but usually it's in, like I said, the forearm or the bicep. One thing you want to make sure is that you will never do you'll never put an IV in, you'll never do phlebotomy, and you'll never do blood pressure in that arm that has that, because one, blood pressure will actually damage the fragile arterial and venous graft. Because, and I say fragile in the sense that they actually seem to look like they're pretty strong, but they're not. So you don't want blood pressure cuff squeezing that to actually cause damage to it. You're not going to do an IV in that arm, because if something infiltrates, it's going to cause damage to that also. This is a patient's lifeline, so it takes almost a year for it to they call it harvest. So basically they sew them together. They wait about a year for it to really become mature and actually strong enough to be used. And again, after that's been used, they're able to start using dialysis, and that's the only way that they're getting toxins out of their body. It's the only way they're actually living. So we just don't want to cause damage to that. And the infiltration of an IV will cause damage to it. See here, there's also a hemodialysis catheter, which you see the picture here. The AV fistula that was in the picture before is usually the most common for people who are chronic dialysis patients. This is actually probably more temporary. It can last for a while, but for the most part, if someone's going to be on true dialysis for like the rest of their life, they're going to go from this device, which is the catheter, to an actual AV fistula. One thing I didn't actually mention too is that when the AV fistula are in the arm, you actually can feel what they call a thrill and bruit. So you can actually feel the actual, like almost a vibrating feeling in their arm. It's kind of creepy, but it's kind of neat in the same way. All right, so let's see here, internal arterial venous fistula and graft. So again, this is what I was telling you about as far as they'll take the artery and the vein, they'll actually sew them together, or they'll actually bypass the two, which is picture B. It's actually, like I said, it's actually really kind of neat. It's kind of creepy at the same time, but it's just very interesting. All right, so let's see here, renal replacement therapy, peritoneal dialysis. So this is where it gets a little interesting, whereas the dialysis is pretty straightforward. Pull blood out, pull it through a machine, pull the blood out, and put it back in your body. This is actually do more of your body, based on what you put into it, will actually pull fluid out and put it into your and more of your abdominal cavity, and then it'll actually drain. So it's actually fairly interesting too. So let's see here, peritoneal dialysis. Goals are to remove toxic substances and metabolic waste and to reestablish normal fluid and electrolyte balance. So it's the exact same thing as dialysis. Its peritoneal membrane serves as a semi-permeable membrane. It does ultra infiltration, and it does peritoneal catheter. And I'll show you a picture in a second. Acute intermittent, it could be also continuous, but allow the patient to be ambulatory, and it's continuous. And I'll explain how this really works in a little bit. Complications can be peritonitis, leakage, and also bleeding. So here's peritoneal dialysis. So basically you have a patient who has a port, which is where this guy's belly button is. And if you actually look at the little smaller box, it actually has where the catheter goes in, and it's actually in the peritoneal cavity of the abdomen. The dialysate goes in. You let it sit there, I believe, for 4 hours. It will actually pull out from the vascular and from the skin, as far as the extracellular space. It'll pull all that stuff into the peritoneal cavity. And once it's pulled in because of the dialysate, after 4 hours, what you'll then do is you'll then take the same tubing in the bag and you actually lower it below the patient, and based on gravity, will actually pull all that stuff out. Sounds really kind of cool, and it's very interesting. What is really nice about this is that with peritoneal dialysis, your patient can do this anywhere. They're going to do it round the clock, but they can be, they can do it at home and then they can go to the mall and then they can actually come home and then do it again and then they can go do something else and go dinner and come back and it allows them the freedom to be able to do this when they need to do it, but do it for themselves. And most patients who have actually had this, they know how to do this better than I could. Sometimes you get a little rusty at some skills, and you're trying to remember off the top of your head how it works. And patients will say, well, here, do this, do this, do this, and this is how this works, and this is how this works. Okay, we're going to set this over here. So for the most part, they really know what they're doing because they do this themselves every single day, several times a day. Uh, with dialysis, the patient is stuck Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, going to a clinic where they actually sit there and it takes 3 hours. And then after they're done, they don't feel well because it's dehydrated them because they want to make sure that they can go every other day without becoming fluid volume overloaded. So they try to pull off as much as they possibly can. So the peritoneal dialysis is probably a little more convenient. The problem, though, is that because of the fact that where the catheter goes in, there's a hole and there's your source of infection. So for the most part, a lot of these patients will get some sort of peritoneal infection, which will require some, antibiotics. And again, this is also their lifeline. So if this doesn't work, what do you do? Create another hole, or do you end up putting them on dialysis, which is what they don't want to do? So there's kind of a fine line between what will work and what won't, and what's going to, essentially, you don't want to do a procedure that's going to kill you because this just didn't do what I was supposed to. All right, so for the nursing process, the care of a hospitalized patient on dialysis for an assessment, you're going to protect vascular access, assess the site for patency, signs of potential infection, and do not use blood pressure cuff or blood draws, which I mentioned before. Carefully monitor fluid imbalance. You're going to monitor IV therapy, accurate eyes and nose, and IV administration pump. So one thing I was going to mention to you also is that with dialysis or even peritoneal dialysis, you will have patients who will still have the ability to urinate, have patients who have the ability to urinate but not as much, and then you actually have some patients who are auric and do not urinate at all. So when I first became a nurse, I thought, oh, you're dialysis, so you shouldn't pee. Well, it is for some but not for others. And so when they are able to urinate, they do have some kidney function. It's just not enough, and the dialysis is what has to be able to pull it off. Let's see here. You're also going to assess for signs and symptoms of uremia and electrolyte imbalance. Regularly check lab data. So again, you're going to have patients who have dialysis, whether it be through a machine, which is every other day, or through a peritoneal, which is at least a couple times a day. But in the same sense, you still have to be able to follow labs to make sure that either you're not pulling off too much or you're not pulling off enough. You're going to monitor cardiac and respiratory status carefully because, again, fluid volume overload is either going to cause respiratory issues or the heart itself is actually either going to work too hard to be able to circulate the volume, or you're going to have high blood pressure and tachycardic. Let's see here. You're also going to assess cardiovascular medications, which must be held prior to dialysis. So when the patient does dialysis, it's pulling off the waste and the excess fluid, and then what they need goes back in them. That actually will lower their blood pressure. So you don't want to give them blood pressure medications, especially if they're, let's say, 120 over 80 or 130 over 85. Then they go to dialysis and now they're at 100 over 70. Dialysis is going to definitely drop it. So, and I also found too that I just hold all the medications just because there are certain medications that will be filtered out through the dialysis machine. So there's no point in giving them all the pills, sending them to dialysis for them to filter it all out, and then you don't know what worked and what didn't. So I usually just hold on all. Let's see here. Interventions for patients on dialysis. You're going to monitor all medications and medication dosages carefully because there are certain medications that are processed with the kidneys, and if the kidneys are not functioning correctly, then not only will it try to process it, but it will also not process them correctly. So let's use the example of you taking a multivitamin. You take it in the morning, whatever your body doesn't need, you usually urinate it out. That's why your urine is so dark from taking the multivitamin. Your patients are the same way. You give them medication, and their kidneys do not have the ability that if they don't need something that they can actually filter it and release it. So you want to make sure you have the right dose, or at least um, renal doses, so that way you're not giving them too much. I had a patient that was on Neurontin, and we had increased the dose because he was having a lot of nerve pain from the diabetes, but because he also was a dialysis patient, that increase in dosages actually made him very lethargic, and it didn't knock him out, but it was enough that he slept a lot. So, and I kind of asked, was like, I'm not really sure why he's acting this way, and the kidney doctor was like, well, it's because we increased the dose, and that's what the side effect was. Let's see here. You also want to address pain and discomfort. I think the dialysis patients tend to have generalized pain. It's Dialysis is very hard on the body, and it does cause a lot of problems with just different systems, and pain seems to be one of the side effects. Dietary considerations: you want to make sure that they're on a low sodium, low potassium, low protein, fluid restricted diet. There's no point in putting them through dialysis and then coming back from it and then having, a steak with, a baked potato and tons of salt and sour cream and everything else, and then washing it down with, a Coke. Um, because all you've really done is just put it back into their system, and they're going to feel like crap the next day. Skincare. So you want to make sure that you try to keep them as moisturized as possible. Patients who are on dialysis are very, 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 very dry skinned. It's because they're dehydrated. We purposely overly dehydrate them to make sure that they're always in the negative. So when they do dialysis every other day, it's shorter runs. They're not having to pull as much fluid off, and they're not putting so much, problems on the heart and the lungs and every other bodily system that's affected by having urinary problems, renal problems. And you also want to do CAPD, which is the peritoneal dialysis catheter care. You want to make sure that it's nice and clean. You want to make sure that you're using alcohol, you're using chlorhexidine. It's a sterile procedure to be able to uncap one and actually attach it to the actual tubing. So, and once you get the hang of it, it's really not that hard. It's almost like doing Foley's. You get in the routine of knowing where to place stuff to keep things as sterile as possible, and this is kind of the same thing. But again, they have a open hole to their insides, and we don't want to introduce bacteria or cause some sort of contamination and cause infection. All right, so when all else fails, and if your patient who is on dialysis is on a transplant list, they are eligible for a kidney transplant. So if they are lucky enough to get one, they will have kidney surgery. So what you want to do is actually go back to your block 2 or your OR pre-op PACU memory, and remember, as far as preoperative conditions and considerations, you do your perioperative concerns, your postoperative management. So you're looking at, making sure the consent form is signed, making sure that they're NPO, make sure they don't take their, pills before they actually have, surgery, making sure they're not on Coumadin or Levinox or any other sort of blood thinning problem or medication. You want to make sure that during the OR that they're able to tolerate surgery, so they're going to put them through some sort of cardiac clearance, whether it be echo or EKGs, or you make sure all the blood work is done to make sure that they're not too thin or too thick, or their electrolytes are off. They have to live through surgery. And then postoperatively, you're looking at, are they bleeding? Does it look like there's any sort of sign of infection? You also want to make sure that they don't have the potential of abdominal distension or paralytic ileus because of the fact that anesthetic slows everything down. So that's including the bowels. So you want to make sure they don't have a problem with that. There's a potential for infection, and there's also a potential for thromboembolism. So postoperatively, don't forget, your patient has a risk for pneumonia, DVTs and PEs, and all the other happy stuff. So, like I said, go back to your block 2 and your pre-op PACU OR memory. All right, so for them to remove the kidney, here's your positioning and incisional approaches. Not necessarily needed to know. I just thought it was very interesting as far as how they place the patient in order for them to remove it. And then you actually have the kidney transplant. I have a friend who recently, about a year or so ago, actually received a kidney, and what they did is they actually kept both kidneys. Neither one of the kidneys were working, but they weren't diseased or they weren't actually causing any anatomical problem. So they usually leave them there, leave everything hooked up the way it's supposed to be. And what they do is they actually took let's call it the third kidney, and they actually put it in in the ileum of your pelvis. So very interesting. In fact, he lifts up his shirt and you can actually see it, and it's kind of creepy, but it's kind of neat. Postoperative nursing management, for assessment, you're going to include all body systems. You're going to assess for pain, fluid and electrolyte status. Because it's a new kidney, you want to make sure that it's actually working appropriately. Patency and accuracy of urinary drainage system. You want to make sure that what kind of goes in is coming out. For diagnoses, ineffective airway clearance based on the possibility of pneumonia, ineffective breathing pattern, acute pain, fear, anxiety, impaired urinary elimination, and risk for fluid imbalance. Complications could be bleeding, pneumonia, infection, and DVT. Postoperative interventions, you're going to do pain relief based on incision and the fact that you've added a new organ. I'm sure there's going to be a lot of pain. You're going to promote airway clearance and effective breathing patterns, so don't forget your incentive spirometer, doing it 10 times an hour. You're going to turn in, cough, and deep breathe, and you also want to make sure that they're positioning themselves back and forth. Two things. One, the more you reposition, the less likely you're going to get pneumonia, and things won't start to collect and settle. But also, repositioning is actually, even if you're 25, 30, 40 years old, you still can get bed sores, even from kidney transplants. So a lot of times they lay in one spot because it's comfortable, and then they forget to actually move, and next thing you know, they're breaking down. You're going to monitor, I think that's, monitor urinary output and maintain patency of urinary drainage systems. So again, you want to make sure that what goes in is coming out. Use strict asepsis with catheter. I think that's just to make sure that, obviously based on the fact that they have a new kidney and them actually having a folate, you don't want to make sure that you don't need to give that new kidney an infection. You monitor for signs and symptoms of bleeding, encourage length exercises, early ambulation, and monitor for signs of DVT. Patient education, instruct both patient and family. So, this is new to them. They are received a new kidney and life is now changed. They no longer have to dialysis, 3 times a week, and they no longer have to feel like crap all the time, and they no longer have to take a million medications in order to survive. So you're almost trying to instruct them on how to go back to the way life was prior to all this happening. Also, education on the draining system, especially the Foley catheter, strategies to prevent complications. You also want to instruct them on signs and symptoms. There's a lot of problems with, it's great that you received a new organ, but your body has to be able to accept it. There's a lot of medications you have to take to make sure that it still continuously works. And you also have to make sure that they understand, signs and symptoms of rejection and infection. And it's not just, hey, I had surgery, I don't feel well. It's, okay, now you've had surgery, you don't feel well, but then there's other issues. Definitely follow up care, fluid intake, make sure that they're staying hydrated, and also health promotion and health screenings. That's it. So 53 minutes. Let me know if you have any questions. I try to be as detailed as possible, but then in the same sense also kind of not go into too much depth. Like I said, I think with the kidneys, it's all about what goes in must come out. If it's not coming out, you want to make sure you're looking at labs to make sure that things are as balanced as possible. And when all else fails, there's a machine that either can take care of it or you hope for a new kidney. So if you have any questions, let me know.